Good evening, everyone, and welcome to our cervical screening, how to optimise the use of self-collection and manage your patients follow-up webinar. My name is Helene and I'm the Workforce Development Officer here at the Westvic PHN, and alongside me in the background is Jade, who's also a Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we are all zooming in from today. We recognise their diversity, resilience and the ongoing place that the First Peoples hold in our community. We pay our respects to the elders, both past and present, and I wish to extend that respect to any First Nations people connecting in today. We commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations, and we'll work together on closing the gap. Just a little bit of housekeeping before we start. The majority of our webinar events are recorded and freely available on our PHN YouTube channel. Jade has it up on the screen at the moment. I have our upcoming events on the screen. You can register for these on our website. Jade will have that link into the chat. Special mention of our upcoming primary care conference. This is hybrid conference where you can attend in person in Geelong, Horsham, Warrnambool or Geelong, Horsham or Ballarat, or dial in remotely. The theme for this year is toddler to teen health, and we look forward to seeing you there. Please make note of the Westvic PHN health pathways on the screen at the moment. Now, if you have entered this webinar, if you have entered this webinar and not displaying your accurate first and last name, please type them in the chat box. Only admin will see these, and this will ensure that we get your certificate of attendance. For this evening's webinar, all participants will remain on mute. If you have questions, please type them in the question and answer box, and then I will ask them on your behalf. Actually, Hannah will ask them on your behalf to the presenter during question and answer. There is a link to the chat box to complete the survey after the webinar, and we will show this slide again at the end. This evening's speaker is Dr. Alexis Butler, a GP liaison physician at VCS, Pathology and Australian Centre for the Prevention of Cervical Cancer. We also have Hannah Saunders, who's a clinical educator manager at and Alexis will be running the poll and question sessions. So I'll hand straight over to Alexis to begin the session. Thanks, Alexis.
Thank you. Can you all see my slides okay? Yes?
Yes, we can see that now. Thanks, Alexis.
All right. Well, thank you for that introduction, and thank you for this opportunity, and thank you everyone for joining us tonight. I want to acknowledge that there's probably going to be quite a broad range of experience in the audience, and I'll do my best to explain things as best I can, because I realise self-collect has given people an opportunity to get involved in cervical screening who possibly weren't so involved before. And so I will try and give some background information on the screening pathways, but also try and give some new information for those of you who are more experienced. So I'll try and please everyone. And I hope that by the end of it, you'll be feeling more comfortable with what is quite a big change, I think, in cervical screening. So tonight we'll cover what is self-collection, and then I'm going to move through quite chronologically, as if you had someone who was coming into your surgery and was interested in self-collection, and you had to work through the thought process of whether they were eligible, and then physically what you do as far as testing and where you can do it and how to follow up results. And please ask as many questions if it's not clear. I'd love to answer all those questions at the end. And if you think of something after the webinar, you know, I'm working at ACPCC during the week, and you can ring us up and ask us then as well. These are the learning objectives. So we'll start off with what is self-collection. Well, really, it's just a simple vaginal swab, but the real take-home message is that it can only be used for testing HPV. You can't use it for cytology. Obviously, since the new policy in July 2022, it can now be offered to all eligible screening participants. So they have the choice between a clinician-collected sampling or this self-collected sampling, but it still has to be overseen and accessed by a healthcare provider, sort of in contrast, I guess, to bowel screening. So since this policy change, we certainly noticed that it got taken up. We had, a lot more self-collection samples coming in at BCS. This is just BCS data. But we also noticed that there wasn't actually that much of a drop of clinician-collected samples. So we're kind of hoping that this is indicating that there's been quite an influx of people who were under-screened. So who can you offer self-collection to? Just say somebody's coming into your room and they say they're interested in self-collection. What do you need to know to see whether they're eligible for it? And first of all, you have to see that they require just an HPV test for their cervical screening. So basically, anyone who requires just an HPV test at any point on the pathway can have self-collection. So the most common reason for that would obviously be the 5-yearly screening, but also 1-year follow-up after a normal or low-grade colposcopy. You can offer either self-collection or a practitioner-collected sample. And if that HPV test is negative, they just go back into normal screening. However, for high-grade biopsies or somebody with adenocarcinoma on a biopsy from colposcopy, they can only be offered practitioner-collected screening because they need co-testing. And I'll go into that a bit later. So they need both HPV and cytology. So I'm going to take, So the other area, the other point on the pathway that you can offer self-collection to is in follow-up of HPV not 16-18 positive results that have normal cytology or low-grade cytology. Now, I'm going to take a deeper dive into this pathway because I think it's helpful to have a better understanding of the pathways now with self-collect, so you know when you can appropriately offer self-collect when cytology isn't needed. Most of the time, the laboratory, I know BCS does this anyway, will, with their recommendation, tell you whether you can offer self-collect with the next test. And so most of the time you can use that, but I guess you won't always have access to a patient's results. And so it's useful to have a good understanding of the screening pathways. So this is the HPV not 16-18 pathway. Of course, if somebody is HPV 16 or 18 positive, that is the much more aggressive types, and they're associated with 70% of cervical cancers. And they just get referred straight to colposcopy. But with the not 16-18s, they are far more indolent and considered not nearly so aggressive and much more likely not to progress. But we still need to triage them to make sure they're not, the type of infection is not more at the aggressive end. So we do cytology to see the effect on the cells. And if that is normal or low grade, we can then allow time for the infection to clear, because we know that most of these infections do clear. So we repeat the test in 12 months. And at that point, you can do a self-collection. And if that test is negative, they just go back to normal screening. However, if it's positive, we obviously triage it again. And if it's negative and low grade, we give it another year to clear. But at that point, you can do self-collection as well. But at that point, if they're positive, they're showing persistence of the infection. So regardless of the cytology, they will be referred to colposcopy. So this second follow-up is actually quite a good time to do self-collection, because regardless of the result, they don't need to go for a triaging cytology if it comes back as positive. And really the management is exactly the same as a physician collected sample. So HPV is detected, they go to colposcopy. Now, here I'm talking about the normal or low risk pathway. Of course, with people who are considered more at high risk, so people who are women who are over 50, or Aboriginal and Torres Strait Islanders, or people who are under-screened, we don't give them so long to clear the infection. And in fact, they only have a year to clear the infection because we consider them high risk. And so on that second HPV test, they would be sent to colposcopy if they were positive. So that second HPV test. Now, how do we check people's history? If you haven't got their previous results in particular, accessing the registry is really the best way to do this. And you can either do this by phoning them, or you can create a Proda account, and or probably the easiest way to do this is to have your software integrated with the NCSR. And then you can just access the patient's notes, click on a button and see their registry history. But this can only be done with some software providers. So Medical Director, Best Practice, Communicare, I think it has to be quite up-to-date versions of these. You can integrate your software. And the contact practice facilitators at PHNs can help you do this. I've discussed this with Jade. They certainly will help you do this at Western Vic PHN. Or you can just access and do it yourself on the NCSR website. And then you can check your patient's history. Do be aware as well, just one thing is, I mean, aside, patients, there is some leeway with labs. So if a patient turns up early, and there's also leeway with the MBS criteria as well. So say they turned up 2 months early for their 5-year test. Actually, you're allowed up to 3 months. You can actually do the test a little bit early, up to 3 months, and they will still be covered by Medicare. So just be aware of that. I mean, that's obviously not ideal. It's good to stick to the correct intervals, but if a patient has turned up a little bit early, you can still do the screening. So the group of people that we really like you to be proactive about reaching out to with self-collect is the under-screened group, because 70% of cervical cancers occur in this group. And the good news is that this group finds self-collection highly acceptable. And also, if they are HPV positive, their studies have shown that they're compliant to follow up. They may need more support, but they are compliant to follow up of HPV positive results. And of course, this will make self-collect a very useful tool in the quest to eliminate cervical cancer, for which Australia is very much on track and one of the leading countries, and we're hoping to achieve elimination by 2035. So who can't have self-collection? Basically anyone who requires a co-test, which is an HPV test and liquid-based cytology. And the biggest group that require this are people that you feel that you need to exclude cervical cancer in. So people who have symptoms that you worries you and make you think, I need to exclude cervical cancer. So of course, the main symptom would be bleeding, unexplained vaginal bleeding, or also if you had unexplained persistent and unusual vaginal discharge, these would be symptoms that you might feel you needed to exclude cervical cancer, and co-testing would be part of your investigation. Isolated symptoms like dyspareunia or maybe short-term discharge are not so commonly associated with cervical cancer, and you wouldn't require a co-test. Now, when you order a co-test for this reason, it is considered to be more of an investigation than screening, and you will find the lab won't give you a recommendation as to when they're due for their next test, but you can be reassured that if they don't continue down that investigation trajectory, that they will in fact at their next when they're next due, as they will be given reminders from the registry at their correct screening interval. The other big group of people that require co-testing is people who are in test of cure, and this is basically for people who have had a high-grade SIN2-3 on biopsy after colposcopy, and then they've had treatment. And this is because we realize that people who've had high-grade biopsies are more at risk of having a high-grade biopsy again, of recurrence. But if they go through this protocol, studies have shown, if they go through this protocol of testing and they pass through it, that their risk has returned to normal, so they can go back to normal screening intervals. And the protocol they have to go through is co-testing annually until they have 2 consecutive negative co-tests. So that's another common reason for co-testing. Less commonly, if people have a history of adenocarcinoma in situ, they require annual co-testing surveillance indefinitely, and much less commonly now, if people have had exposure to DES in utero, they need co-testing as well. So all these people, all these groups cannot be offered self-collection. So basically, just to cut a long short story short, what you need to do before offering self-collection is check for symptoms and check their screening history. So I'm just going to talk about a case study, because I said to you that we're talking about, I'm going to go through this as if you were thinking of offering someone self-collect. So just say you've got a patient, she's 40 years old. This is okay because the screening age group is 25 to 75. She has no symptoms, and you look at her NCSR history, and she's got no history of high grade, and her last test 11 months ago was a non-16/18 positive with normal cytology, and the previous tests prior to that have all been HPV negative. And the recommendation on this was to repeat in a year. So just the first poll question here, can you offer this lady self-collect? Okay, so hang on. So nearly all of you have said that you can do self-collect, which is right. And I suspect that some of you have said, no, you can't because she's come in early by a month, which is fair enough to think about. But as you remember, I did say that there is some leeway with labs. So you can actually do a test on this lady 1 month early. And this is a follow-up of a non-16-18 positive with normal cytology. So her next test initially will be an HPV test. So it's perfectly appropriate to do a self-collect. Okay, so moving on. So the next important thing is, what should you discuss with participants to help them make the choice of whether they do self-collect or not? And I think the first thing you've got to do is make sure that you assuage any worries that they have. And I think the first worry that they're going to have is this as accurate as a physician collected? And you can absolutely assure them that yes, it is as accurate as a physician collect, because after all, HPV doesn't just sit on the end of the cervix, it's got a field effect all over the vagina. Now, the next thing that studies have shown worries them is that they're actually taking responsibility for this test. So they are, whilst before it was you, and they worry that if they do it wrong, that they will get a false negative result, a false normal result. But you can absolutely reassure them that that won't be the case, because there's quality control measures in place for both assay failure because of contaminants, and also for the most common cause of an unsatisfactory result, which is a lack of cellular material. And in both these cases, the result will come up as unsatisfactory and not as a negative or normal result. So what causes an inhibition of assay? Well, any vaginal application actually can, if it's at a high enough concentration. So probably the main culprits would be lubricant, particularly lubricant with carbomer in. But anything like canesten, if it's at a high enough concentration, can. Blood and discharge can, but they've got to be at a very high concentration. So basically, if somebody's menstruating and it's not too heavy, they can go ahead with the self-collect if they don't mind. Interestingly about self-collects, we are finding that the unsatisfactory rate, and this is from VCS data, is a little bit higher than clinician-collected unsatisfactory HPV tested. Now, clinician-collected unsatisfactory HPV rates are 0.2%. And those for self-collected samples are actually more of the order of 2%. But we can't really draw conclusions from this yet, because as I alluded to earlier on, we feel that self-collection is largely occurring in underscreened populations, and they may be behaving differently from the general population. So, for instance, studies have suggested that one of the reasons for a lack of cellular material, which I said was the most common cause of unsatisfactory results, may be that some women are actually not doing the tests, they're doing air swabs. So just be aware of that. After having settled their worries about self-collect, you probably want to compare the two options for them so that they can make their choice. So obviously you let them know that they both identify HPV infection, and obviously, very importantly, self-collection doesn't, you can't do cytology on self-collection. But as far as management of most of the results, it is the same. So most of the results are going to be HPV negative, 90% of them, and that will be the same management in both cases, clinician collected and self-collected. 16 or 18, 2% of the results, both will go to colposcopy. Of course, the fly in the ointment is the HPV not 16, 18 group, which is about 6% of the population. And as I mentioned when we were talking about the HPV not 16, 18 pathway, they need a triaging cytology. And that can be done, obviously, on a clinician connected, on the same thin prep sample, but for a self-collect, they need to return to have a clinician collected sample for cytology. Now, with unsatisfactories, with a self-collect, you don't have to wait 6 weeks. They can return, the next day. So that's something that's a little bit different as well in management of results. And I have noticed sometimes that can be a bit confusing, because on some of the flow charts, they've kind of merged the clinician connected and the self-collected pathway and said if there's an unsatisfactory result, it needs repeating 6 weeks. But really, if you're doing a self-collect, you don't have to wait that 6 weeks. Now, with the HPV not 16, 18 results, I've said that they're overall for the general population, they're about 6% of results, but this does vary depending on age. So if you're younger, your HPV not 16, 18 rate is much higher, it's about 17%. But if you're older, it's of the order of about 3%. So that might be something to take into account when you're discussing these two methods. And this is for the general population. So this is a BCS screening resource that we have that pretty much goes through what I've just presented, and is useful to have when you're talking to a patient just about their choice, so that you can check that you've gone through everything you need to tell them. So let's just get back to our patient now. She was 40 years old. She had no symptoms. We looked at her history. Remember, she had no high grade. She just had a not 16, 18 positive. And we all decided that you can offer her self-collect, which you can. But interestingly, although I've said with the general population, the incidence of not 16, 18 results is 6%, if someone's already had an HPV test, a positive HPV result, their chances of being HPV positive again are actually of the order, HPV not 16, 18, sorry, we're talking about, if their chances of being HPV not 16, 18 positive again are of the order of 60%. But so you might, somebody who's already in the rooms and not so worried about cervical screening might decide that it was more worthwhile to have a physician collect if they knew that, because they didn't want to take the chance on having to return to cytology, which is actually quite high, of the order of 60%. We don't know yet what the repeat positivity is on the third test, but that is what it is on the second test. You might also want to talk to them about how to take a self-collected sample and explain the process to them. This is a resource that we have on the website, and the thing that most women seem to worry about is getting the swab up to the red mark, which of course is difficult when you can't see the red mark. That's what they quite often say. And of course, the easiest way to help them to do that is to say to put your fingers on the red mark so you can feel it when it gets to that level. But really, they don't have to get it up the canal that far. They can just, if they just get it past the keratinized area of the vulva, that's probably going to be good enough. And if it wasn't, you would get an unsatisfactory result rather than a false negative. So even though this woman has a 60% chance, because she had a not 1618, our case, of having another not 1618, she's decided that she wants to have a self-collect. So what equipment do you use? Well, the most commonly used swab is the 552C or the 552C.8. But check with your lab, because every labs have a slightly different swabs, but this is what we use at BCS, and it is the most commonly used swab. We also can process other swabs, and also we are accredited to process these swabs during pregnancy, but not all labs are accredited to process swabs during pregnancy. So just check with your lab. And the other thing is that you can actually do chlamydia and gonorrhea on these swabs. So you can, it's a bit of a one-stop shop. You can do your chlamydia and your gonorrhea and your screening. Now, these do need to be processed within 28 days. So do remember to put the date of collection on the sample. If the patient is taking the swab away, you need to ask them to put the date of collection on the swab. Other labs have other processes as well. Be aware of this. There's something called the Roche method, whereby you're meant to swirl the swab in the thin prep. This is not BCS, although we can process these if you do send them in. So, but we don't require this process. We, on the whole, use the dry swabs. So I'm telling you about this because even if if your lab doesn't use this method, you may hear that other doctors or healthcare practitioners are using this method and think, well, maybe I should be sending a thin prep in, but just be aware that there is this other method. And anyway, you swirl the swab in the thin prep, and then you send the thin prep to the lab, or you can send the thin prep and the swab if you want to the lab, but it's the thin prep that's going to get processed. But what you must be very careful of is that on the request form, you make it clear that it was a self-collect swab, because you don't want them processing it as if it was a physician-collected swab if a cytology is needed. And something else I learned today, which was interesting, is that actually this method has a fairly high unsatisfactory rate of the order of about 4.7%. And I think most labs are now trying to get accredited for just using the swabs. But yes, this is a method that some of them do still use. So that's the swabs that you use. Where can you do the testing? Well, obviously, it must be ordered and overseen by a healthcare professional, but within those confines, the models can really be quite flexible so that you've got the highest chance of success. So You can help someone do a sampling and still call it a self-collect, and that might give you an opportunity to look at the vulva if there was something clinically that made you feel that that was necessary. Some patients like being helped with the self-collect sampling, and that's perfectly acceptable. Or it can be the other extreme, and you don't have to be present when they're doing a sampling. It can be done in a toilet. Or even VCS has got a home-based self-collection process, so that you can actually initiate the whole process at distance, say through a telehealth consultation. And you can actually then request home-based self-collection by faxing a request form through to us, and we will send instructions and reply paid kit to your patients, and then they can send it back to us. Has to be sent back within the 28 days, and then the process is pretty much business as usual. We send you the results. We also obviously let you know if the patient doesn't send the test in, and we also will check the eligibility of the patient before we actually process it. So this can be useful for remote communities, for patients with agoraphobia, patients who can't leave the house. It was started really during COVID times when it was particularly helpful. But really, it has been found through studies that actually clinic-based sampling gives you the best chances of a successful outcome. So if you can get them to do the sample before they leave the clinic, that's probably ideal. So I'm just going to go through another case study with you now. And we're going to poll some questions and go through the answers. So I've got a 29-year-old patient called Nadia, and she's pregnant, and she said she's never had any cervical screening. She's very anxious about the process. Can you offer her self-collection? So I need the poll up. Here we go.
I've just ended poll there now, Alexis.
Sorry?
I've just ended that poll there now.
Okay, all right. So I think probably the best answer to this, you could say yes. I think, you know, she's a good patient. She's never been screened before. She's nervous. She's pregnant. But I think the very best answer is you need more information, because we don't know that she hasn't got symptoms. And if she's got symptoms, she needs co-testing. So she shouldn't be offered a self-collect. Also, maybe you want to double check with the registry that she really hasn't been screened before. And the other thing is you would need to check with your lab that they're accredited to process samples during pregnancy. But the most important thing to exclude is that she doesn't, she doesn't have any symptoms before offering her the self-collection. Okay, so so basically you've now worked out that she's able to have self-collection. She's what sort of things would you include in your discussions with Nadia to help her make her choice? And you can obviously answer multiple questions. You can answer, it's a multiple answer question. Okay. Okay, that's great. The most important thing to say to her is that it's just as accurate as the physician collected sample, so that's great. She is quite young, so she's actually got a 17% chance of having to come back for cytology, of getting an HPV not 16/18 and having to return for cytology. Obviously you wanted to do the test correctly, but I really you don't want to make her anxious about getting it right. And really, as we said before, she's not going to get a false negative result if it's done wrongly, because we've got quality control measures in place that will make sure that she actually just gets an unsatisfactory result rather than a normal or negative result. So you probably wouldn't want to sort of put her off, make her anxious about that, I think. Okay. Stop sharing. All right. So she chooses self-collection, but refuses to do it in the surgery and asks if she can take the swab home. Is that allowed by Medicare? Yeah, that's an easy one. So the answer is yes, she can take it home. So she's done the test and she's dropped it in. And of course, the results are HPV not 16/18 positive. What's the correct follow-up for this woman? Return for co-test in 1 year, refer to colposcopy because she has never been screened, return for cytology, physician collected. Okay, 100%, great. Okay, so because she's got an HPV not 16/18 result, she needs to, this is her first HPV not 16/18, as her first screening test ever. She needs, but it is the first result, she needs to have a cytology. She needs to return for that triaging cytology that we were talking about. So she needs to have that done as a physician collected, so she needs to return for that. If that's normal, she can then return for another HPV test in a year. I think we'll probably leave that there because I want to have time for any questions that we've got rather than doing the second part of the study. So have we got any questions?
So we've got a question that's come through regarding co-tests, and the question is one-off bleeding following intercourse an indicator for a co-test?
Is what, sorry, one-off bleeding?
Yeah.
Postcoital bleeding. Yes, it is an indication for a co-test. And it actually, if they have one episode of postcoital bleeding and co-test is negative, and and they don't have any further postcoital bleeding, the guidelines actually say that you don't have to refer or further investigate. But obviously, I would consider, particularly as you can do a chlamydia on these tests, both thin prep, on a thin prep, I would obviously be thinking about, excluding STDs like chlamydia, possibly gonorrhea. But if you just have one episode, co-test is normal, and it doesn't reoccur, you don't have to necessarily refer them. And it certainly is a very good indication for a co-test.
Okay, thank you. The next question that's come through is, when is the earliest to return for a repeat test if due in 12 months and in 5 years?
That's a great question. And so most labs, my understanding, even if it's a year, there is a leeway of 3 months. So you can actually come back at 9 months or at 4 years, 9 months, but not a day earlier. That's the absolute limit. Does that answer your question?
Yes. So we've got another one that's come through about also for patients who have had a hysterectomy, is it recommended now that they all have a cervical screening test? A lot of my patients are getting letters to have one after decades of not having one.
No, they're not. It's not all recommended that they have one. In fact, if somebody has a hysterectomy for benign reasons and their screening has been benign and the histology of the hysterectomy is normal, they don't need any further screening. What we have been finding has been happening is that when we talked about the test of cure for if you have a high grade, and we have found that women who have had high grade findings from colposcopies prior to their hysterectomy and haven't completed a test of cure may suddenly find that the registry seems to, the IT systems seem to have picked up on this, and they will ask them to return for to complete a test of cure. So often the reason for why they've been recalled lies in the history of what their screening history prior to hysterectomy, or obviously what was found at hysterectomy. But if everything is benign and the pathology of the hysterectomy is benign, all test of cures were completed prior to the hysterectomy, and they haven't got anything like adenocarcinoma in situ, they don't need any further screening. But that is a very tricky area because you've got to, often you don't have the histology, and yes, it can be very difficult.
We do have a nice little summary guide of the recommendations post hysterectomy from VCS, so I can include that in. I'll pop a link in the chat shortly, and can include it in the follow-up email as well, if you'd like. Okay, keep your questions coming through because we do have a little bit more time. So please pop them into the Q&A function. We've got one more at the moment, and it's about requesting chlamydia and gonorrhea. And do you need to a separate request slip, or do you just add to the cervical screening request?
Just add it to the cervical screening request. And we are actually as well thinking of, we may well have trichomonas as well in the future. And but at the moment you can actually order chlamydia and gonorrhea not only on the self-collect swab, but also on the thin prep sample as well. And I really think, particularly if you've got young women with postcoital bleeding or intermenstrual bleeding, that, you know, rather than jumping straight to a co-test, I would be, you know, thinking about the chlamydia and gonorrhea side of things, first of all, because you don't want them being investigated unnecessarily. And quite often in that age group, there's quite a lot of not 16, 18 going around. It's just acute infections. So you really want to exclude that they've got, that they haven't, particularly in the younger age group, that they haven't got chlamydia and gonorrhea, first of all, which are a far more likely cause of the bleeding than, you know, a screening abnormality.
Okay, and on chlamydia gonorrhea, there's another question about whether that test is a PCR.
Yes, it is.
And once again on the same topic, okay to
Yes.
request gonorrhea and chlamydia if sorry, I'll say that again. Just to summarise, if you request gonorrhea and chlamydia if someone's symptomatic, used to be opportunistic and for no symptoms.
Yes, you can still do that as well. Yes. So I mean, it's just because we're talking about being able to do it when you're screening, you know, on the same test. But yes, no, you can. Obviously, it's ideal to do it on, you know, sexually active women to check, particularly chlamydia.
Another question on this is that can all labs do chlamydia and gonorrhea or just VCS?
Ooh,
Do we know that?
I would think, yeah, I would think most of them could. It's really the pregnancy issue that seems to be something that not all labs are accredited to do. So that's something that you have to be aware of. That's why I brought in that case. And, you know, I said you need more information because the case about Nadia who was pregnant, because you would need to check that your lab actually is accredited to process cervical screening samples on somebody who's pregnant. I mean, they're all, hopefully things will settle down soon and we'll all be accredited and we'll all be using roughly the same methods. It's just a sort of a bit of flux at the moment as everyone's trying to get accredited. And we're very lucky at BCS because we seem to be accredited in nearly everything because we are quite often involved in the accrediting processes. So, yeah.
And I've just popped a link in there. We've got another question on hysterectomy, and just to let people know, I've just popped a link in the chat with a link to a resource which has got a nice little table about management post hysterectomy as part of it. The question about hysterectomy is if the hysterectomy is partial, does the person still not require a cervical screening test?
Oh no, absolutely. If they've had a subtotal hysterectomy, which, you know, is not often done these days, but certainly in the past, they need cervical screening just as per usual, basically, because they've still got a cervix. So no, definitely subtotal hysterectomies, you still need to, they need to be screened just as normal. It's only the total hysterectomies that that don't need screening if everything looks benign. If you're unsure of the history, the guidelines do allow for, they do actually say that if it actually says if the patient has no cervical screening history, which of course, you know, how often do you get a patient who's got absolutely no cervical screening history? But I have confirmed that also if you feel they've got an inadequate screening history, i.e. you haven't got the histology, you can do just 2 HPV tests a year apart, and if those are both negative, it is possible to cease screening.
Okay, excellent. I've got another question on pregnancy and regarding pregnancy samples. Is there any recommendation for what trimester a self-collect is done?
Okay. Nobody has shown that cervical screening increases the risk of miscarriage. So you could do it really at any point of the pregnancy. And with a self-collect particularly, you're only talking about HPV testing. So you don't have to worry about the effect of the pregnancy on the cells, because it used to be, you know, when we were doing pap smears, there used to be concerns that the cytology wasn't so accurate if you did it. It was affected by the hormones of the pregnancy. But that's not the case with an HPV test. So you can really do it at any time of the pregnancy. I mean, obviously, if they were anxious and they had a lot of miscarriages, I mean, you know, I would leave it until after the first trimester. But as far as the guidelines are concerned, you know, screening should go on during pregnancy. And there's no concerns about doing it gently in the first trimester. Remember, we've only really got to get past that keratinized area of the vulva. But as I say, if it's got to use your clinical judgment, I guess. I think, yes, so I think that's all I had to say about that. Yeah.
Okay, and there's another question about 70 to 74-year-olds. And the question is, why are some 70 to 74-year-olds age exited and some age exiting? Can you shed any light on that, Alexis?
Some age exited and some are age exiting.
Age exiting.
They should all have one last HPV test between the ages of 70 and 74, period. So they shouldn't have exited by 70. And actually, you know, it was, I felt sorry for all these women who thought they had exited, and then when HPV screening came in, they all got reminders to come back because we used to have an earlier age of exiting. So, and I think it's a very good note to end on, to have an HPV test between the ages. I think it's important that they have that test to be HPV negative. And, you know, you're at higher risk of high grades in cervical cancer in that age group if you are HPV positive. And so because of that, if you are HPV positive with any positivity, so even if it's a non-16, 18 in that age group, you are actually should be referred to colposcopy in that age group. So it's very important that you do have that test between 70 and 74.
All right, so we've just got
answer that question. I hope that was.
There is another question about if women can opt in after the age of 74. Like
Absolutely, they can, but they're not going to get reminders from the registry. But as long as they come at correct screening intervals, they won't get invoiced or anything like that. It will all be covered.
All right. Well, we are coming up to time. There is one more. I think it's more of a statement than a question, saying the government is sending every woman between 70 to 74 years old a letter saying they may need screening now that the age has been extended, and it's not coming from the registry. So that is a comment rather than a question. And that, yeah, communication is going out to people that are 70 to 74. And as you say, do feel a bit sorry for them, thinking they've all finished up and they're being asked to come back. Fantastic. All right. Well, we have managed to get through all of those questions, I think. So thank you very much. There's some fantastic questions in there. We are just coming up to 8 o'clock. So I might just bring up my screen very briefly. And I am going to, we will follow up with a email with some additional education opportunities that are available. And you can also call VCS anytime if you've got any questions after this session. So please reach out to us. You can speak to the lovely Alexis or her colleague, Dr. Wendy Pakes, and they're always willing to answer your questions. We have a couple of CPD, online CPD courses that are available. If you'd like to go a little bit further with your learning about cervical screening, we'll include that in the follow-up email. Just a quick plug for some resources that we've got available, as well as a collaboration with VARCHO. If you see Aboriginal and Torres Strait Islander clients in your practice, you can order these beautiful resources, which are available by contacting the VARCHO Cancer Journey team. That's our number. Once again, that will be included in the follow-up email. And I will hand back over to Helene to close up.
Thanks everyone for attending our webinar tonight, and a special thank you to Alexis. Excellent. It was such a good presentation, full of great information and really well presented. And a huge thank you to Hannah, who did the polls and the questions. It was excellent work. So thank you everyone for attending. Please don't forget that evaluation survey and contact Hannah or Alexis if you've got any question follow-ups from this webinar, and I'm sure we will see them both again in some of our future education. So thanks everyone for attending. Have a good evening. Bye.